Endoscopic submucosal dissection for superficial gastrointestinal lesions, European Society of Gastrointestinal Endoscopy, ESGE Guideline, Update 2022. Introduction. This guideline represents an update of the guideline on the role of endoscopic submucosal dissection, ESD, for superficial gastrointestinal GI lesions, published by the European Society of Gastrointestinal Endoscopy, ESGE, in 2015. This evidence-based guideline was commissioned by ESGE. It addresses major issues concerning ESD, that is, evaluation before ESD, comparison with other therapeutic strategies, namely endoscopic mucosal resection, EMR, and surgery, and management after ESD, to inform and underpin the use of this fundamental technique for the treatment of superficial GI lesions. This guideline does not address the skills and knowledge that the endoscopist should have to perform ESD or the specific management of antithrombotic or other medications in the peri-procedural setting or quality measurements, as these are addressed in separate guidelines. A companion technical review will be published separately that will cover prevention strategies regarding ESD complications and detailed technical issues. Main recommendations. ESGE recommends that the evaluation of superficial gastrointestinal GI lesions should be made by an experienced endoscopist using high-definition white light and chromoendoscopy, virtual or dye-based. ESGE does not recommend routine performance of endoscopic ultrasonography, EUS, computed tomography, CT, magnetic resonance imaging, MRI, or positron emission tomography, PET-CT, prior to endoscopic resection. ESGE recommends endoscopic submucosal dissection, ESD, as the treatment of choice for most superficial esophageal squamous cell and superficial gastric lesions. For Barrett's esophagus BE-associated lesions, ESGE suggests the use of ESD for lesions suspicious of submucosal invasion, Paris type 01S, 02C, for malignant lesions larger than 20 millimeters and for lesions in scarred or fibrotic areas. ESGE does not recommend routine use of ESD for duodenal or small bowel lesions. ESGE suggests that ESD should be considered for en bloc resection of colorectal, but particularly rectal lesions with suspicion of limited submucosal invasion, demarcated depressed area with irregular surface pattern or a large protruding or bulky component, particularly if the lesions are larger than 20 millimeters, or for lesions that otherwise cannot be completely removed by snare-based techniques. ESGE recommends that an en bloc R0 resection of a superficial GI lesion with histology no more advanced than intramucosal cancer, no more than M2 and esophageal squamous cell carcinoma, well to moderately differentiated with no lymphovascular invasion or ulceration, should be considered a very low-risk curative resection, and no further staging procedure or treatment is generally recommended. ESGE recommends that the following should be considered to be a low-risk curative resection, and no further treatment is generally recommended. An en bloc R0 resection of a superficial GI lesion with superficial submucosal invasion, SM1, that is well to moderately differentiated with no lymphovascular invasion of 20 millimeters or larger for an esophageal squamous cell carcinoma, or 30 millimeters or larger for a stomach lesion, or for any size for a BE-related or colorectal lesion, and with no lymphovascular invasion, and no budding grade 2 or 3 for colorectal lesions. ESGE recommends that, after an endoscopically complete resection, if there is a positive horizontal margin, or if resection is piecemeal, but there is no submucosal invasion and no other high-risk criteria are met, this should be considered a local risk resection, and endoscopic surveillance or retreatment is recommended, rather than surgery or other additional treatment. ESGE recommends that when there is a diagnosis of lymphovascular invasion or deeper infiltration than SM1 or positive vertical margins or undifferentiated tumor, or for colorectal lesions budding grade 2 or 3, this should be considered a high-risk, non-curative resection, and complete staging and strong consideration for additional treatments should be considered on an individual basis in a multidisciplinary discussion. ESGE recommends scheduled endoscopic surveillance with high-definition white light and chromoendoscopy, virtual or dye-based, with biopsies of only the suspicious areas after a curative ESD.